friends. Hello. Happy Tuesday. We'll give it just a minute to let some folks join on, but we're so thrilled you chose to spend your Tuesday, either lunch hour or I guess late morning or early afternoon, depending on where you are with us. So hang tight for just a minute. I'm watching people jump on. Nice to see y'all. If you would, feel free to just jump in the chat real fast on Zoom. Let me know if you can hear me. Just a quick test on audio, visual, all that kind of stuff. And then we will go ahead and get rolled. Just send me a chat real fast. Let me know. And then we'll be off and running. Awesome. Thank you, friends. Appreciate those that chatted in. Let me know. Give it just a couple of seconds, couple of housekeeping things before we go ahead and get rolling today. We've got an awesome session planned for you. Really excited for what we're going to cover. Just some fantastic content. We use the chat functionality. We try to keep it really simple at Provider Trust. So if you've got a question as we go through the session today, please don't hesitate to ask us in the chat. We will jump in, get it answered. And if anything that we can't get answered live, just because of the sake of time, sometimes these 30-minute blocks go pretty fast. We'll make sure you get it answered immediately, right after the session today. Today's session, we are recording it. We will send you, after the session today, we'll send you a copy of the slides, as well as the recording. So if you want to, you can go back and go listen, and you'll have all the resources that you need, as well as today's session is good for CEUs. So you will get the CEU information from our team, usually by end of day today, and if not, pretty quickly tomorrow. First thing tomorrow morning. So be on the lookout for that in your inbox. We try to send it all at once. So CEU information, slides, and recording. With that, let's go ahead and get rolling. It looks like everybody has joined on. Thanks again for taking the time. Today, we are talking about how smarter exclusion monitoring creates a safer healthcare. This is a topic that is near and dear to our hearts at Provider Trust. We talk about it often. Really, we talk a lot about exclusions, and every now and then, this is actually my personal favorite topic to talk about. We bring the patient back into the forefront. Sometimes it's our perspective that we talk often about a smarter healthcare makes a safer healthcare at Provider Trust. And when we think if we can do these things well and make healthcare just a little bit smarter, we can make it a lot safer for patients. And so we're gonna cover certainly the exclusion stuff today, but we're gonna go a little bit into some of the research that's been done on the patient side too. So again, very near and dear to my heart, and it's something that we like to talk about at Provider Trust. If this is your first webinar with us, I'm going to give you a quick overview of who we are and what we do. We're Provider Trust. We are made with love in Nashville, Tennessee. We're based here. We are a compliance monitoring company that we monitor about 5 million either providers, employees, vendors, all kinds of healthcare records on a daily basis to try to catch either excluded providers, any sort of fraud, waste, and abuse to keep healthcare safe. We have a solely focused in healthcare. We spend so much time in data and analytics in the primary sources and just understanding healthcare data and how to best implement, leverage, and activate that across healthcare organizations. It's what we do best, and certainly what we spend a lot of time talking about. We produce a ton of content, give it all the way for free. And so if you're joining webinars with us today, we do webinars at minimum on a monthly basis. We also have just tons of resources on providertrust.com. Our goal and vision is that if we can capture the insights that we see in monitoring these millions of records and get it to each of you in a timely fashion, we can keep healthcare safe. We can do it together and alongside each of you. That's a bit about what we do. We believe, I mentioned this as well, we believe that a smarter healthcare makes a safer healthcare. And so the quick tagline, you'll find this on our website, is just from healthcare license verifications, from exclusion monitoring to total enterprise compliance, we have developed a platform that actually does this type of work. So we partner with compliance, we partner with HR, we partner with payer organizations as well to just keep healthcare safe. That is all I'm going to say about us, and then we'll get into the topic today. Today's agenda, here's what we're going to cover today, is understanding the OIG Exclusions 101. I'm looking at some folks on the phone, and some of you I certainly recognize, and we've met before, either in person or I just know your name because you've joined a webinar before. And actually, for about half the call, this is your first interaction with Provider Trust. And so for those that are new, this just a quick Exclusions 101, just to make sure we level set in the world. We've got the same facts that we're going off of. And if you have been to a webinar with us before, the very first part, it'll be a quick refresher. We'll go into exclusions by the numbers. We do a ton of data analytics on exclusion data, what exists in the world and where the gaps and the holes are that potential fraudulent providers might actually slip through. We're going to talk about protecting healthcare's most vulnerable, the patient population. We're going to talk about the future of compliance and where this is going. We have heard directly from the OIG. We've heard from primary sources. We pay a lot of attention and spend a lot of time trying to understand and predict the current trend in the industry. And we've got some pretty cool updates in section 4. And then 5, just leaving you with some insights and some takeaways from here. So getting started, just understanding the OIG and Exclusions 101. We actually presented alongside the OIG at this year's HCCA conference. It was virtual, but we did a presentation that was a deep dive into the OIG. That is actually, it's on our website, providertrust.com, if you want to search for that to get the full hour-long, just a real deep dive into trends and analytics around how the OIG actually views this data and what they do with it. We're going to keep this super high level just to start and just to make sure we're all on the same page as it relates to exclusions and kind of what that means in the world. So getting started, what is a program exclusion? They're administrative and remedial. Protects federal healthcare programs and beneficiaries from untrustworthy providers. Just again, at a glance, what it means is that no federal healthcare program payment may be made for items or services either from individuals or entities. That includes directed or prescribed by excluded individuals as well. The primary source guidance talks a lot, not just about employment or subcontractor relationships, but also about prescribing, ordering, referring relationships as well. It applies to all of that. The mere submission of a claim is all that's required for penalties apply, given the nature of the relationship. Exclusion applies to direct providers, doctors and hospitals, and indirect providers as well, drug manufacturers, device manufacturers. We see this stuff all the time. There are federal OIG and state Medicaid exclusions. Those are different exclusion agencies, which we'll cover in a second. And the best primary source guidance I can give you, we'll make sure we send this out after the call as well. We always do after webinars on exclusion related topics, is the Special Advisory Bulletin on the Effect of the Exclusion, which published in 2013. But it details exactly each type of relationship, and specifically from the OIG, what is being covered. The OIG Exclusion Authority, again, bit of a refresher for those that may have indulged in our content before, but the OIG has the authority to exclude individuals and entities from participation in any federal healthcare programs, according to the Social Security Act. There's 2 types of exclusions, mandatory and permissive. And again, the effect is still the same, regardless of whether it's mandatory or permissive. And to keep us breezing and go into the stuff that y'all are joining on for, really quickly, where do exclusions start? These are the top 5 reasons, top 5 places that exclusions actually originate from. At the state level, Medicaid Fraud Control Unit, because of a licensure issue, a healthcare-related misdemeanor action, defaulting on a student loan, or a healthcare-related felony action as well. Just a quick note, what we see, the licensure action, about 43% of exclusions actually start because of a licensure issue from a state licensing board. And so we advocate, it's not the purpose of today's call, but we advocate tremendously for a holistic compliance approach because we believe that you can actually catch some of this stuff way upstream and actually keep your population safer and be able to identify fraud quicker with a bit of a predictive analytics approach that aggregates, looks at all of these sources and catch things before they actually become an issue. And I mentioned this before, just the effect of an exclusion. This is the screenshot, excuse me, published May 8th of 2013. This is that OIG's special advisory bulletin. It's about 12 pages, maybe I may give or take about a page or two. It's about a 12-page document. It's just absolutely worth the time to dig through. Make sure you read it. If you don't have a copy ready, it's something that we actually encourage everybody that works at Provider Trust to read and reread and continually to keep it surfaced, because it really is it prescribes exactly what we need to do to make sure we're all certainly in compliance with regulation and what is best practice in the industry to keep us safe. Talks about frequency. We talk often about frequency, scope, and the breadth of who we're actually monitoring. It covers all of those in terms of scope, frequency, who's included, what types of populations, and so we'll make sure you have that. But that is what we base a lot of analysis on. So with that, let's get into the fun stuff. Exclusions by the numbers as we start to look at the data and science and some of the trends behind all of this. Exclusion, facts, and figures. 2,378 individuals and entities were excluded by the OIG in 2020. So looking backwards towards 2020 for a second. 546 individuals and entities were reinstated by the OIG in 2020. That's actually a very consistent pattern. As we start to look at the OIG's patterns of behavior back multiple years now, we've been in business for about 11 years. So we pay very close attention to the behavior by the OIG, especially as it relates to publishing new exclusions on a monthly basis. That sort of 2378, it's pretty consistent year over year about new published exclusions. Certainly as we're getting into the world of new published exclusions, the reinstatements are starting to tick up a little bit year over year as well. But as we look across the whole universe of exclusion data, there's consistently being new exclusions added to that universe that we all need to know about, stay on top of. Looking again backwards to 2020, the top 5 exclusion reasons in 2020. The first one was a program-related conviction. The second was a license revocation. The third was healthcare fraud. The fourth was patient abuse or neglect. And the fifth was controlled substance conviction. Each of those have unique codes. So they actually say it'll tell you the reason for the exclusion. In some sort of monitoring effort or product, we recommend that you actually keep track of that stuff, because it can relate right back to the primary source and give you a lot of detail as to why and what the nature of the exclusion actually is. We found that it may vary on how you treat specific cases in the future, but those are the top 5 exclusion reasons in 2020. The top subject types for exclusions are physicians, other licensed individuals like an RN, business owners or executives, or employees of the private sector. So when we think about populations and where we typically interact, it's most often with these 4. And then the last, we've got 3 more slides on just the basics of exclusions, and we'll get into the patients. Exclusion referral sources. These are where exclusions come from. So OIG special agents, there's an awesome presentation that I referenced earlier on our website that talks a lot about those agents, their territories, and how they actually work on a day-to-day operational basis. It's worth the read if you're interested in reading a little further. OIG attorneys resolving civil investigations. We've mentioned Medicaid fraud control units, other federal agencies and law enforcement partners, state Medicaid agencies, CMS's Center for Program Integrity, professional licensing boards, and environmental scanning. So newspaper articles and internet story and on where this stuff typically comes from. Monitoring sources. Here is the world of exclusions, and then we'll go into a little bit about who's actually involved in all of these as well. Monitoring sources, for sure, there's the OIG LEIE. There's also the SAM.gov. Quick note about either of those. Really putting this on your radar. We care deeply about making sure everybody has the right information as soon as you have it. The OIG announced this year that they are kicking off an effort to modernize the LEIE, change the way it can be accessed, change some of the data requirements. They're really taking a hard look at the LEIE as a data source. They've kicked off an effort to modernize it over the next 2 or 3 years. It's really, everyone on this call has some sort of exclusion monitoring process, certainly us included at Provider Trust. Would recommend you stay really close to that effort. because that's actually, it's something that we're paying attention to say, how can we best access, leverage, and gain analytics from a primary source to best serve our clients. But certainly if you're using this in any capacity and with any type of organization, making sure we stay on top of that is pretty critical. The second note is actually about SAM.gov. SAM.gov, formerly known as the EPLS or GSA, just actually rebranded and relaunched. We were just, if you follow Medicare compliance today, we were actually quoted, our co-founder Mike Rosen was quoted just this week in talking a little bit about the SAM.gov relaunch and what that actually means. It's a new website, it's a new interface. So if you are part of your effort or monitoring process is going to SAM.gov as the primary source, making sure that that's on your radar just in case it changes anything in your world. Just big updates, right? It's not often that an exclusion list updates like that. And we kind of have the two federal sources, both are going through some modernization. And there's 42 state Medicaid exclusion lists. There used to be 43. Arizona stopped publishing their own list and instead just deferred entirely to the LEIE. So if you come across other stuff in the industry that says 43, know that 43rd list is Arizona, which no longer updates. They just defer to the LEIE entirely. And certainly there's a universe of others that are not technically exclusions, but good to know. Medicare opt-out preclusion list from CMS, OFAC, SSA, DMF, right? So at a minimum 44, the universe of 44 lists to monitor. Spending just a minute on state exclusions, right? We talked about, there's a lot of challenges with these as a primary source. Many of these state lists are not published on a routine or scheduled basis. Many have extremely limited data. A really good example of this is Alabama's state Medicaid exclusion list has only first and last name and address. There is no unique identifier at all. So we advocate pretty strongly for a data science strategy to complement some of the gaps and the holes within the primary sources. But overall, it's a tough list to use just because it's largely incomplete data from the primary source. Varied list type, y'all know this well. Some of these states publish in spreadsheets, some of them publish in PDFs. Some of them are just on a website in terms of where they live. Almost all of them do not publish unique identifiers, social security number, MPIs, tax ID, something that you can verify with authority and say, yes, this is absolutely without a shadow of a doubt the same John Smith, that is my employee. And we see this all the time, right? The slide says appear to have late reporting to the OIG, but they have late reporting to the OIG. The average time for a state exclusion to appear in the OIG LEIE is 173 days. So if monitoring the state lists initially is not part of your strategy, there potentially is a delay in being able to keep our patients safe. The challenges, I mentioned some of the challenges as well. Here's just a few examples. You see on the left, 60%, this is Texas, 60% of the providers excluded by Texas's state list are not OIG exclusions. So understanding the gaps between some of these primary sources becomes imperative and critical to an effective monitoring strategy. 100% of these state, looking at the lines on the top, 100% of these sources are missing date of birth, 98% are missing NPI number, and 100% of Colorado's list is missing address. And then there's a couple of facts below as well, which is 48% of Louisiana exclusions are not on the OIG LEIE. 77% of Arkansas exclusions are not on the OIG LEIE. And 72% of Colorado exclusions are not on the OIG LEIE. And I apologize, I think the bold numbers on the top actually refer to the state below. They're not separate. So the 100% missing date of birth applies to Louisiana. 98% of missing NPI numbers applies to Arkansas, and 100% of missing address applies to Colorado. The final slide on exclusions is just the state of the exclusion in 2021. We talked a lot about 2022. Here's where we live in 2021. There's 74,310 OIG exclusions, 70,746 SAM, and 73,533 state. all of those numbers continue to increase on a monthly basis. We are adding to our universe that we are constantly paying attention to on a monthly basis. That's 218,519 total unique healthcare exclusions to be aware of. 50%, right, across the whole universe, 50% of all state exclusions never show up on the OIG LEIE, right? Never show up. That's the universe to pay attention to. So now let's talk about protecting healthcare's most vulnerable. So understanding the world of exclusions, how do we actually leverage that to actually tell a story around protecting the patients and creating a safer healthcare for everyone? We wanted to highlight this. There's a couple of studies that we're going to highlight along the way, but a recent study from Bloomberg, patients treated by healthcare professionals later excluded from Medicare were between 14 to 17% more likely to die than similar patients treated by non-excluded physicians, nurses, and other professionals. Below, the study also found that patients treated by providers later banned from Medicare were 11 to 30% more likely to experience an emergency hospitalization in the year of exposure. Another study that we've seen come out, we'll pay a ton of attention to this. This was 2019 in the Journal of Health Affairs by Johns Hopkins. Actually took a look at excluded providers and the beneficiaries that they treated. And over a 3-year period, they looked at 1,364 excluded providers that treated over 1.2 million Medicare beneficiaries and received more than $630 million in Medicare payments. So taking a look at all of that in 1 year of that data that's showcased in the Johns Hopkins study, how many patients does an excluded provider treat? That answer is 333 in an annual year. How many services does an excluded provider deliver per patient? Is 24 per year. How much money does an excluded provider receive from Medicare? Is $168,000. And what's the average payment per patient to an excluded provider as well, which is $500. Those are some of the highlights that came out of this Johns Hopkins study. And then they started to look at demographic information as well to say, as we're thinking about the patient that's most likely to interact with excluded providers, who is that patient, right? Who is the patient that receives care from an excluded provider, and what does he, she, they look like in the world? And what the study found from Johns Hopkins is that that patient is most likely to be non-white, is more likely to be disabled, is more likely to be under 65, and more likely to be a dual enrollee in Medicaid as well. The study went on to say the Medicare patients and understanding race and ethnicity Medicare patients treated by excluded providers are more likely to be Black, Hispanic, Asian, or another minority group. When they took a look at medical diagnosis, the Medicare patients treated by excluded providers are more likely to be diagnosed with depression, chronic kidney disease, diabetes, or heart disease. And so as we take a minute and pause and look at the human side of exclusions in the delivery of healthcare, right? As we know that those who are most vulnerable and least protected suffer the most. And as we go back and look at this, and again, you'll get the slides, but as we go back and look at this and understand racial implications, as we understand medical diagnosis implications, what we actually advocate for at Provider Trust is to connect the work that all of us do as compliance and HR officers directly with where these patients are being seen and the workflows that are actually involved in patient care. That's everything from the order or the claim to patient scheduling to staffing and delivery. And so we're advocating for the future of compliance to be a connected one. Exclusion monitoring, as we envision the future of exclusions and do so with the patient at the forefront and top of mind, we advocate strongly that we take the data that we have and actually move it upstream to say, before a patient is treated, how can we better connect the data that we pay attention to with the workflows, processes in place that are most likely to treat those same demographic or diagnosis implications for patients across your health system or across your membership if you're a payer. And we know we have a few payers on the phone. What does that mean? Right? I'm talking a lot in hypothetical, but what does that actually mean when we say the future of compliance is connected? And for us, what that means is just seamless integration for exclusion data to be all the way up front to seamlessly integrate via an API from your HRIS to your EMR to your contract management tool or to your applicant tracking system. It's a lot of what we do at Provider Trust, but it all comes back for the patient. We believe deeply that if you can move exclusion monitoring upstream, you can best protect patients before there's any type of interaction with an excluded provider. And so the way in which we do that, we're not going to get into today, but that's what when we think of the future of compliance and exclusion data specifically, we advocate that it moves upstream. The last thing I'll share on this topic today before we wrap, I know it's just a quick 30-minute one as we're moving to a close, is the vision for us. And what this can be is, how do we take a single identifier and transform it into a picture of an entire provider instantly? When we say exclusions, we don't just we mean exclusions, and we also recognize that there's other things that are critically important to know in each of those workflows to best protect patients. And so if we're thinking about the patient in mind, what are the things I need to know and verify instantly? And at what points of care delivery to be able to say without a shadow of a doubt that yes, this doctor or this RN should be delivering care. They meet our standards of eligibility, and they meet our patient care and patient safety standards as well along the way. That's the vision for a lot of what the work that we do at Provider Trust, but it's also the vision of where we think that the industry is heading. And I mentioned earlier that at HCCA this year, the OIG announced that they're modernizing the LEIE. Specifically along the lines of modernizing the LEIE, they mentioned the need to release their data and make it accessible by API to do this exact thing. And so the way the market in the industry is going is actually to make data accessible and more interoperable. So that way at time of care, we can all collectively lean in and keep patients safe. Friends, as we wrap up today, what I would, if you're looking for more detail on this or more information, just in exclusion data, my gosh, we have tons of resources and they're all free at providertrust.com. Just click the drop down and click resources and go in and just grab whatever you like. We have everything from interactive exclusion maps to Medicaid lists by state, links to the primary source. We do a ton of deep dives, source by source as well. Would certainly advocate that you spend some time in our resource library. Again, it's all free. And we've heard from our clients over the years that it actually makes for fantastic training for our folks and for our users, the folk that even use our product applications and interact with our platform. We found that the resources there have been really good to get them up to speed quickly. That is where we'll end. As always, thank you again for spending the time with us today on this Tuesday. We've got an awesome string of webinars coming up over the next couple of months as well, talking about what to expect from enforcement, trends and perspectives with the new presidential administration, to digging deeper on license and credential primary source data as well. So be on the lookout for more primary sources coming from us. As always, if you've got any questions at all, feel free to reach out to us. We'd be happy to get you pointed in the right direction or get you any answers you need. And on that note, we just hope you have a wonderful rest of your Tuesday, and we'll be in touch soon. Thanks, friends, for spending the time. Have a fantastic rest of your Tuesday.